All right, welcome to today's Explainer. Today, we are diving into a really high-stakes clinical analysis tailored specifically for you future pediatricians and neonatologists. We're going to look closely at the critical, often life-threatening mistakes made in the ICU when treating infants under 1 year old who are battling severe community-acquired pneumonia and stage 2 respiratory failure. Look, when a fragile life enters your intensive care unit, knowing exactly what not to do is honestly just as important as knowing what to execute.
You know, babies aren't just tiny adults. Because of their unique anatomical and physiological features, pathological processes don't take days to escalate. They accelerate in mere hours. A minor delay, a slight miscalculation in your parameters, or even just a missed diagnostic cue can rapidly snowball into a fatal crisis. In the infant ICU, the margin for error is absolute zero. Literally every single decision you make has immediate, visceral consequences.
Here is our roadmap for today. We'll be moving through 6 vital steps: dangerous diagnostic flaws, respiratory therapy errors, incorrect antibiotic selection, infusion therapy and hydration, syndromic treatment major errors, and we'll wrap it all up with a life-saving clinical conclusion. Let's jump right in.
Starting with Section 1, Dangerous Diagnostic Flaws. This is all about the initial assessment.
The battle is usually won or lost in that very first hour. And a deadly mistake we see constantly: over-reliance on technology, specifically trusting only the pulse oximeter reading. You just can't stare at a monitor and assume you know the patient's status. The correct tactic? You absolutely must assess general clinical intoxication. Look at the baby. Are they apathetic? Are they overly excitable? Is there perioral cyanosis even when they're at rest? Are they using accessory muscles, flaring their nostrils, or showing intercostal retractions? If you ignore these physical signs of hypoxia and brain involvement while just staring at a glowing screen, you are costing yourself vital intervention time.
Let's talk about this highly deceptive number, 88 to 92%. This is a super dangerous blood oxygen saturation threshold when the infant is breathing room air. At stage 2 respiratory failure, an infant might show this number, and you might think, okay, well that's not catastrophic. But that number is often masking severe underlying distress. Plus, you might listen to their lungs, hear no wet rails, and just assume it's simple bronchitis. But atypical pneumonias caused by things like chlamydia, mycoplasma, or RSV, they often don't present with wet rails. They show interstitial changes on an X-ray. If you underdiagnose right here, that infection is going to rapidly evolve into lobar pneumonia.
Moving on to Section 2, Respiratory Therapy Errors. This is how we manage that failing breath.
When choosing oxygen therapy, please never just took a 6-month-old up to simple high-flow nasal cannulas. Simple cannulas do not create positive pressure in the airways, which means they are completely, absolutely useless in preventing alveolar collapse. The correct, life-saving tactic as your first line of defense is utilizing CPAP, continuous positive airway pressure, or true high-flow nasal cannula therapy so you can actually maintain that vital positive end expiratory pressure.
But hey, you also have to recognize when non-invasive support is failing. If CPAP just isn't working, the infant is getting exhausted, bradycardia is setting in, and your blood gas analysis shows a PaCO2 exceeding 60 millimeters of mercury, you are in highly dangerous territory. Waiting too long to transition to invasive mechanical ventilation when the patient has decompensated acidosis is a massive error. But on the flip side, rushing to intubate aggressively when it's not quite needed yet, that brings its own set of absolute terrors.
And that terror is barotrauma, the catastrophic rupturing of delicate infant alveoli caused by aggressive artificial ventilation. I mean, just imagine the sheer fragility of an infant's lung tissue. When an aggressive intubation strategy is forced upon it, the pressure literally tears the lungs apart, leading straight to a pneumothorax or pneumomediastinum.
So how does that tearing actually happen? Usually, it's by setting the ventilator's tidal volume way too high, to 10 to 12 milliliters per kilogram. An infant's lungs simply cannot handle that volume. The absolute protective norm you must use is 6 to 8 milliliters per kilogram. Anything more than that, and the ventilator itself becomes the weapon that injures your patient.
All right, Section 3, Incorrect Antibiotic Selection. Welcome to the pharmacological battlefield.
When dealing with severe community-acquired pneumonia, your empiric antibiotic selection has to be immediate and aggressive. Never, ever use monotherapy, like plain ampicillin, for stage 2 respiratory failure. You're very likely dealing with mixed flora, maybe pneumococcus combined with staphylococcus. The correct tactic is the golden combination therapy.
third-generation cephalosporins, like cefotaxime or ceftriaxone, combined with macrolides, like azithromycin, so you can simultaneously cover those atypical pathogens.
Now, how you actually deliver these drugs is just as critical. A huge mistake we see in the rush of the ICU is giving these antibiotics via intramuscular injection. Let's think about the pathophysiology for a second. Severe hypoxia and shock completely destroy peripheral microcirculation. So if you inject a vital antibiotic right into the muscle, it's just going to sit there in the tissue, totally unabsorbed. The correct tactic? Intravenous administration only, direct to the bloodstream.
And, we absolutely have to talk about the de-escalation principle. Out of sheer panic, a physician might start an infant on a maximum strength reserve antibiotic, like meropenem, and honestly, that's justified initially. But failing to narrow the spectrum once those culture results return, that breeds highly dangerous hospital-resistant superbugs that cause severe long-term systemic damage. You've got to de-escalate as soon as the data allows.
Next up is Section 4, Infusion Therapy and Hydration. Let's talk about fluid management.
We are stepping onto a really dangerous tightrope here, where good intentions often lead to literally drowning the patient from the inside out. The major risk is interstitial pulmonary edema. In severe pneumonia, the infant's pulmonary capillaries already have increased permeability because of hypoxic damage. If you pump way too much fluid into them, hyperhydration, you drastically increase that hydrostatic pressure. That liquid has absolutely nowhere to go but straight out of the vessels and into the alveoli. You are essentially flooding their lungs, rapidly pushing that poor baby from stage 2 to stage 3 respiratory failure.
To stop that horrifying reality from happening, you must follow the golden rule of restrictive hydration. Never, ever exceed 70 to 80% of the infant's physiological fluid need. You have to keep them on a strict restriction regimen and closely monitor diuresis. In this scenario, less is absolutely more.
Furthermore, what kind of fluid are you actually using? Pumping 5% glucose exclusively is a huge mistake. It acts almost like free water in the system, stripping the body of electrolytes and inviting deadly complications like hyponatremia and, terrifyingly, cerebral edema, which is brain swelling. The correct tactic is using balanced crystalloids, like Ringer solution or a proper sodium chloride balance, to maintain physiological equilibrium.
All right, Section 5, Syndromic Treatment Major Errors. This covers the maintenance care phase.
It's in this phase where seemingly routine, everyday pediatric treatments become outright lethal in the ICU. Consider this: an infant's airway is roughly the diameter of a drinking straw. Because of these incredibly narrow bronchi and weak cough reflexes, giving strong chemical mucolytics like Ambroxol or acetylcysteine triggers what we call the flooding effect. The sputum volume expands violently and the baby literally drowns in their own secretions. Giving strong mucolytics to an infant in this state is a massive, massive error.
So what is the safe alternative? You want to rely on mechanical and gentle chemical assistance. Use isotonic or hypertonic sodium chloride inhalations to thin the mucus safely and use electrical suction aspiration to physically remove it. Crucially, avoid heavy sedatives to keep the baby quiet on the CPAP machine. You simply cannot afford to suppress their natural respiratory drive. And finally, use frequent postural drainage changes to prevent hypostasis or blood pooling in the lower lungs.
Finally, we arrive at Section 6, the life-saving clinical conclusion. Your ultimate survival protocol.
Let's bring all of this ICU chaos into one definitive checklist. Error: high-volume ventilation over 10 ml/K. Result: barotrauma. The tactic: protective ventilation at 6 to 8 ml/K. Error: aggressive fluid infusion. Result: pulmonary edema. The tactic: strict fluid restriction to 70–80%. Error: using Ambroxol. Result: drowning in sputum. The tactic: postural drainage and saline inhalation. Error: delayed or single antibiotic therapy. Result: septic shock. The tactic: IV broad-spectrum combination therapy within the first golden hour.
We've unpacked the science, the major pitfalls, and the exact protocols necessary to keep these highly vulnerable infants alive. Understanding this framework allows you to confidently make differential tactical choices when you're under immense pressure. So I want to leave you with this final thought. When a fragile life enters your ICU, will you rely on dangerous habits, or will you execute the precise tactics that save them? The margin for error is zero. The choice is yours. Keep learning, stay hyper-focused, and use this knowledge out there to save lives.